Good evening, everyone. Once again, I would like to welcome you on the Lebanese E-Society for Oral Implantology. Today, we will receive Dr. Naji Aboud. He is DDS, CES, and DU Paro from the University of Paris. He is specialist in perio. He is running his private clinic in Beirut and in Kuwait. He's focusing on perio and implantology, dentistry, and advanced regenerative procedures. He is author for several papers, and he is international lecturer in these subjects. Hello, doctor. How are you?
Good evening for you, Muhammad. I know that you are in Paris, confined as we are here. And good evening also to all my colleagues and friends that are watching us tonight. It's a pleasure to be.
So you made your studies in Paris, near my home, huh?
Yes, I was there. Unfortunately, I didn't know you. I don't know if you were there during that time. I was there from the years 93 to 96. I did a CES in periodontology and in the EDU in periodontology in Garancière and Pitié-Salpêtrière.
Yeah, Garancière, well-known university. Also Pitié-Salpêtrière. It's a big, huge one. Yeah, they have a good program. I know some teachers there. Mm-hmm. And you stayed how many times there?
I stayed in Paris for about 3 years. I reached Paris at the beginning of 93 and I left Paris maybe in February or March of 96. It's nice to remember those times in Paris. I think that Paris is one of the most beautiful cities in the world, and still it is.
This is what I wanted to tell you. I think you have good memories there, no?
Sure.
Yeah. So today you will talk to us about the complication, about the failures. We all have failures, and we all don't know sometimes how to handle it, how to do it. So it's really nice subject, and it will help us a lot. So I will leave you with this subject to tell us. I can't wait. I would like to learn from your experience. So please, the stage is yours.
Okay. So as the title shows, I will be talking tonight about I don't know, but I'm not seeing myself anymore in the screen.
Yeah, it's normal, doctor. When you put your screen, PowerPoint, you're not saving yourself.
But you are seeing my screen.
We are seeing you, and you can see yourself if you open another screen.
Okay, very good. So we'll be discussing the management of catastrophic failures in implantology and in bone grafting. So, okay. So as I'm trying to, I tried to say the Dr. Daniel that invited me, it will not be a full or a magistral lecture. So I won't be showing statistics, I won't be showing publications, and I won't be showing comparative studies, just showing you those cases and tell you how the diagnosis, the treatment plan, how they were treated, and the outcome of the treatment. Okay, I'm seeing on another screen the group, but I'm not seeing my screen and the other group that...
You have to refresh the group, refresh your contact.
I will try to do it again.
The page on Square Root, and you can see it here. I am seeing it.
Yes, okay, no, because I can see you, but whenever you go, I see a black screen. I don't see my screen.
Actually, we are not seeing your PowerPoint. You didn't activate your PowerPoint yet. We are seeing your screen. It's black.
No, it is on. It is on.
Oh, why? Can you share it once again? So, please.
My full screen now is the PowerPoint. I will take it out again, but you want me to share with you again?
Yeah. Take it and share it once again.
I stop the screen and I share again?
Yeah, please.
Stop screen. And share screen again. Okay. Can you see my presentation?
No, not yet. Please.
Now?
No, nothing. Share the screen. Okay, it's coming. Oh, great.
Now, do you see it?
Good, yeah.
Okay. But I don't see it on the group.
It will come. There is a delay of a few seconds.
Okay,
but we are seeing it.
Okay, so let's start with the first case. As you know, those cases, failures, we are seeing now more and more failures because a lot of people are doing implant dentistry, and a lot of those people actually do not have this experience in implants, and they think that whenever the implant is osseointegrated and it's stable in the mouth, they think that this is what we need and this is what we want. But actually, this is not what we need and we want. This is not sufficient. This is necessary, but not sufficient. To have a long-lasting and very good prognosed treatment, you have to have really a good quantity and the quality of tissues around the implants. Your treatment plan must be ideal because the implant treatment actually do not count in 2, 3, or 4 to 5 years. The implant treatment must be always in place and in good health for more than 15 to 20 years. So I received this patient, this 48-year-old lady, in my clinic, maybe two or 3 years ago. She told me that she had an implant treatment that was done for her since 4 years, and since that time, she's not feeling comfortable. What were her complaints? Actually, she told me that since the time that she had the prosthesis connected to the implants, she had a very bad smell in her mouth. Her gums were always swollen, and she had a continuous and slight pain and discomfort. And she was unhappy with the aesthetic results. Extraordinarily, when I was talking to her, I realized that really, aesthetically, this is not acceptable for a 48-year-old lady. She's still young, she's not more than 70 years old, and we barely can see her teeth even when she is smiling in her excessive smile. As you know, we can see now in this picture, we can see only 2 or 3 millimeters of teeth when she is smiling maximum, while this amount of teeth must show in the position of rest without any smile. So when doing the smile, they must show more than this. So we can now think that maybe we have a decrease in the vertical dimension, and surely the dimension of the anterior teeth is very short. So when I tried to examine the patient intraorally, first thing I realized is really the very bad smell that was coming out of her mouth. It was really a bad smell. Even I was placing one mask, I placed another mask so I could really come close to this patient. What did I realize? First of all, I looked at her, I can see an acrylic prosthesis on the upper jaw, but it was fixed. So this acrylic prosthesis was screwed to the implants. And I can guess that the doctor that treated her tried to do for her a hybrid prosthesis on implants, but instead of eliminating the buccal flange, he kept the buccal flange. So the patient really couldn't do any cleaning above the prosthesis. And so everything she was eating was getting stuck under this prosthesis. And imagine the amount of food that was stuck here since more than 4 years. And imagine the smell that was coming out. So there was no buccal flange and no palatal flange. The patient really couldn't clean under this prosthesis. This is how we can see the prosthesis. You see that there are no opening in this area around the prosthesis, so the patient can clean with interproximal brushes. The panoramic X-ray showed that we have a complete hybrid prosthesis in the upper maxilla. We had 6 implants. A lot of bone around those implants was missing, and we can guess because of the inflammation and infection caused by the food impaction in this area. So we have a bone loss around the implants, a very advanced peri-implantitis. We can see also that in the lower mandible, she had 3 implants, 1 implant on number 46, 34, and 36. We can see that the implants on 36 and 46 also, we had maybe 50% of bone loss around them. As you know, the panoramic X-ray is not sufficient to establish a good treatment plan, so we took a full mouth paraapical X-rays, and we realized actually we confirmed what we saw in the panoramic X-ray. We saw a lot of bone loss in the maxilla, and above all, we don't have bone, neither on the posterior or the anterior maxilla. On the anterior maxilla, maybe we have 7 to 8 millimeters of bone, but on the upper right and upper left, there is no bone actually. In the lower mandible, it's 50% or a little bit more of bone loss around the existing implants. We can confirm this on the CBCT. You can see that on number 15 here, we have missing maybe half of the buccal bone. Around 13, the tooth number 13, we have 2/3 of missing bone on the buccal side. Around tooth number 12, it's the same thing. Number 21, 23, and 26. So, what needed to be done for this case? Okay. First of all, the diagnosis. In the upper jaw, what was the cause of what we have here? It is actually a bad conception of the prosthesis that led to an almost complete bone loss. So maybe the implants were placed right, maybe there was sufficient and good quality of tissues around the implants, but the bad prosthesis that was placed later on actually led to this bone loss. As for the lower mandible, the bone loss around the posterior implants was caused by either an occlusal trauma or occlusal trauma, maybe the occlusion was not right, and also because the 37 and 47 teeth were not present, so there was too much occlusal load on 36 and 46, and maybe there was not sufficient tissues quantity at time of implant placement. The only implant that was really good, or there was no problem around it, was the implant on number 34. So what was the treatment? The treatment is, of course, the removal of all upper implants and lower posterior implants. We had to keep number 34. The teeth were not to be touched because there was nothing wrong with them. Then doing bone grafting on the upper and lower maxilla and mandible, placing new implants and placing new prostheses. The most important thing in this treatment is the sequencing, because we have to take into considerations the patient wishes. What are her wishes? First of all, this patient wanted a reliable treatment, and she didn't want us to take any risk or taking any chance of having a low prognosis for her treatment. She wanted a treatment that will last for her for the next 15 to 20 or maybe 25 years. Second, she didn't want to stay without any teeth. Third, she didn't want to have any removable prosthesis. She couldn't support the idea of having a removable prosthesis. So we had to deal with all this and establish a treatment plan. So our treatment plan was to start with a fabrication of an upper temporary fixed prosthesis attached to the old implants. We will use the old implants just to fix a temporary, and this will enable us to be working around the implants, doing our bone grafting and placing our own implants. Then doing a bilateral sinus elevation, because on both sides we could elevate the bone on both sides and have a good quantity of bone on both sides, so we can place 4 implants from each side, from the first premolar to the second molar, and maybe placing 1 or 2 anterior implants if possible. This will be actually decided during the surgery. Then placing a new hybrid prosthesis, of course eliminating the buccal and the palatal flange and keeping spaces to clean. As for the lower, we had to remove the implants on number 36 and 47, 46 and 36. Then doing at a later stage a guided bone regeneration around 36 and 46. Then new screwed crowns on 36, 37, 46, and 47. So we started by removing the existent prosthesis, and I won't tell you what did I find under this prosthesis. You know, food impacted since more than 4 years inside, so very bad smell and very bad situation. So we removed the prosthesis, we took an impression on the existent implants, and we sent it to the lab, and we prepared this hybrid temporary prosthesis without any metal. It's just acrylic. Two of the abutments were screwed because the angulation of the implants was actually beneficial for us to place screwed on them, and the other abutments actually will be cemented. So we placed the abutments that needs to be cemented on, and we placed the temporary prosthesis. First of all, this temporary prosthesis, as you can see, we had enough space on the apical area to clean. We increased the vertical dimension because this prosthesis actually was like a test for us to see first of all, the increase in vertical dimension, if the patient will support this, and if she will have any TMJ problems later on. If she will have, so we can decrease the vertical dimension, because we really increased about maybe 5 millimeter the vertical dimension. And we made longer anterior teeth. So the patient was really happy with the result, and she was like rejuvenated of maybe 10 to 20 years. You know, whenever we increased the vertical dimension after this big decrease, the patient looked younger, and she was really happy, and actually the smell completely disappeared, but the problems are still inside. We can also guess with this picture that the prosthesis needed to be, the anterior teeth needed to be shortened for the final prosthesis. Maybe shortened, maybe a decrease of a little bit of the vertical dimension. We will decide this later on. So the prosthesis was in place, so now we are ready to start our bilateral sinus elevation. So without removing the implants, we just did sinus elevation with a lateral approach on both sides. Finished sinus elevation, and we placed back the hybrid prosthesis. As for the lower implants, we removed the 2 implants. As you can see, the big bone loss around them, and we closed the flap. Okay, so the implants were removed. 1.5 months after the removal of the lower implants, we did guided bone regeneration on the lower right and the lower left. You can see here the fixation screw on the lower left. We actually didn't need to place them on the lower right. And you can see here the elevated sinuses on both sides above the existent implants. And we waited for 6 months for the upper jaw. Then we re-entered again, and we removed the 2 most posterior existent implants that she had, and I placed implants on 14, 15, 16, 17, implants on 24, 25, 26, and 27, and 2 small and short anterior implants, and I kept her implants. So the situation was like this before doing the surgery. The situation was like this also after the sinus elevation. The situation was like this when I placed my implants and before removing her old implants. So you can see the number of implants that are in place in the upper jaw. 3 months after the placement of my implants, I removed her old implants and I transferred my temporary to my existent implants. So I placed temporary abutments on implants number 15, 14, 21, 22, 24, and 25 also, and I placed back the temporary prosthesis but fixed on those implants. 3 months after, we took the impression and we placed our final hybrid prosthesis. Okay, now actually 8 months after the guided bone regeneration in the lower jaw, everything was ready to place the lower implants. So the lower implants were placed in ideal position. implants on 36, 37, 46, and 47. This is the final picture of the upper prosthesis. You can see enough space to clean between the implants, and all the interproximal brushes could enter easily in this area. And we actually stay with the patient around 1 hour after the final session, just trying to teach her how to brush and how to clean those areas. This is the lower jaw. You can see the screwed implant, crown on implant placed on 36, 37, and 46 and 47. And this is the upper jaw. Okay, and this is the final smile for the patient. As you can see, we reduced a little bit of the length of the anterior teeth. That's the second case. This patient consulted me some years ago. She was sent by another fellow dentist. She came to me in this situation. So as I can see, I can guess that this is a temporary prosthesis and it was hiding something. So I removed the temporary prosthesis and I saw this big defect. This big defect actually was caused by a car accident. This patient had a car accident. We can see also, before doing the lip retraction, that this is really a difficult case. Why? Because we have a horizontal and vertical tissue loss, hard and soft tissue loss. We have also a big factor, which is the gummy smile. She had the gummy smile. So everything that we will place, it will show whenever she smiles. So we cannot do something not sure, and we cannot actually place something with a crown on the left side bigger than the right side. To complicate things more, whenever we retracted her lips, we realized that she had implants placed actually by another dentist. She had implants placed in a very apical position. Imagine this patient, 28-year-old lady, beautiful, having her implants restored with a central incisor on the upper left higher than the central incisor on the upper right of 6 millimeters. Imagine that. She smiles, one big tooth and one small one. And a lateral on 22, which is higher than the other two. It was really not acceptable. And the patient felt that. This is why she consulted the other dentist that sent me this patient to try to fix that. It was really a challenging case. On the X-ray, we can see that we had two completely osseointegrated implants. They were stable, nothing was moving. We had an infection on tooth number 11, and it had to be removed. The CBCT also confirmed what we saw and actually gave us also another indication. The implants that we thought that they were completely osseointegrated, actually, we can see that on the buccal side of those implants, we didn't have any bone. So imagine the apical position of those implants. And even though the apical bone on those implants was not existent, we had only 2 to 3 millimeters of bone on the buccal of those implants. So imagine, where is the bone? The bone is maybe 2 or 2.5 centimeters, maybe, on the apical side. So what will be our treatment plan? Our treatment plan is to do everything on different stages. We cannot do this treatment all at once. It's one miracle at a time. First of all, we have to remove the 2 implants. Number 11 also had to be removed. Then doing vertical and horizontal bone regeneration in this area and trying to bring the tissues coronally. Doing a crown lengthening on all other teeth to, first of all, reduce the gummy smile, and second, trying to bring the 2 levels next to each other. That means trying to bring the anterior sector more coronally and both sides more apically, so we can bring the 2 levels, bringing them at the same level. And at the end, doing the prosthetic treatment. We started by removing or extracting the 2 existent implants. We did this without any surgery, just we used torque and special instrumentation, and we unscrewed those 2 implants. It was not hard to do because those implants had only bone on the buccal side, on the palatal side. And now I had to decide if I had to extract 11 or to keep it. Actually, 11 had to be extracted. But because I saw on the x-ray, and we can see here that we had a little bit of bone on the mesial part. So I said to myself, this bone on the mesial part of 11 was really a good thing for my regeneration. So it could bring some bone cells laterally from this side toward my graft that I will place in this area. So I decided to keep number 11 for now, to do the regeneration, then to extract it later on. Okay, this is what I decided to do, to keep 11. You can see here that we have a lot of tissues on the mesial of 11. But actually, so we started the surgery, we did the incisions, and I opened. So my decision to keep number 11 was a bad decision because we couldn't see what I saw now in the surgery. The infection that was on number 11 was reaching the area where I would be placing my graft. So there was an infection risk. If I placed my bone here, I did my grafting, my graft would have high chances of doing an infection. So that we must here be really categorical. We cannot take any chance. So at this stage, I decided to extract number 11 and not to do the bone grafts. So we extracted number 11, we cleaned very well in place, we did a very good curettage, and we closed again. And we waited also for another 6 weeks for a complete healing of the soft tissues. As you can see here, the gum level is still going more apical, and the opening above the temporary is getting bigger. So again, same incisions as before, 2 teeth apart from each side, and intracrestal incision, full thickness flap, of course, cleaning the bone very well. Here we can actually see that we have a 6 millimeter vertical bone loss on the palatal side, and we had a 12 millimeter of vertical bone loss on the buccal side. So imagine the quantity of bone that we had to create just to bring it to the normal. Of course, when doing a vertical regeneration, we have to use autogenous bone that is mostly removed from the ramus area. It is the most simple area and the most quick area to remove from. So we removed bone, we prepared everything in the bone mill in small particles. We fixed the membrane. This is also a titanium reinforced non-resorbable membrane, PTFE, EPTFE. So it was fixed from the palatal part first by screws and pins. Then we placed the bone. We placed a good quantity of bone just to reach the area wanted, and we closed the membrane. This technique, it's called the sausage technique. That was actually firstly described by Urban. This technique, actually, whenever we close the membrane, we keep on placing bone under the membrane just to make it more stable. Okay, so we placed the membrane and we continued on compacting the bone. I think yesterday, I think, or 2 days ago, you asked Dr. Jeff why he was using a mix of autogenous bone and xenograft. If you want, at the end we can discuss this matter. Okay, so everything was closed. Of course, passivations of the buccal flap to close everything, and the suturing is actually a combination of horizontal major sutures and separate sutures. And the patient actually traveled for 8 months or 9 months, and she came back after 9 months. First thing, she came to me just to take a look at the surgery, at the area of the surgery. We can realize that, first of all, she had a lot of plaque. And I can understand that because those patients are really traumatized and they are really afraid of coming to this area to clean. Although we told the patient that you have to clean, you have to clean. But she told me, I'm afraid, I don't want to come. around this area, and I don't want to touch it. Nevertheless, the quantity of tissues that we can see under the temporary is really satisfying. Now we have just 2 millimeters or 2.5 millimeters of difference between number 21 and number 11, which is really a huge success. So we now it's time to place the implants. We reopened back, and we did the crown lengthening on both sides. We opened, we reached the membrane area, the membrane was removed, and you can see the quantity of bone that we gained. So this was the situation at the start before doing the bone grafting, and this is the situation 9 months later on. We can see a huge amount of bone, a very good quantity vertically and horizontally. So now we can place our implant in optimal position. So we started by doing osteoplasty and osteectomy around the existing teeth for the crown lengthening, and then we placed the implant and everything was sutured back. Those are the implants, and we placed temporary on the implants. So this patient she's not living in Lebanon, so she comes every few months just to do some stuff, and then she goes back. So this is another set of temporary that was placed by the restoring dentist, now trying to manipulate the tissues, trying to gain as much papilla as he wants, as he can. And this is our third case. This patient actually was referred to me also for a periodontal treatment. As you can see, a generalized bone loss. We treated this patient by multiple sessions of scaling, root planning, hygiene education, periodontal flaps, bone grafting around the teeth, and he needed to do, we needed to extract number 48 and place implants on number 46 and 47. Unfortunately, the CBCT showed us that we do not have too much width of bone. We had between 2.5 and 3 millimeters width of bone on 46 and 47. And the best indication and the less traumatic indication in this case was to do a bone splitting or a bone expansion, a ridge splitting. In this case, I used the Meisinger kit. So we do here a vertical incision in the bone. We do a crestal incision in the bone using discs, and or maybe we can use piezo. I have both. It depends on the case. As you can see here, the two ridges were a part of 3 millimeters or 4 millimeters away, and I could place two implants here in ideal position, and we grafted this area, of course, later on, and we closed the flap, and I took this x-ray. Here we can see the vertical fracture line as seen on x-ray immediately after the implant placement. This is what I do, and this actually procedure, I do it maybe once or twice a week, okay? So this was maybe my 125 case done like this. The thing that I forgot to tell you is that the patient, when I actually consulted him first, told me that he was really a heavy smoker. He used to smoke 3 to 4 packets of cigarettes per day. So I told the patient that we cannot do the treatment if you continue to smoke this way. So he promised me that he will stop smoking at least during our treatment. And this is how I started working for him. The patient called me 1 week later on, and he told me that he was still in pain. The patient was still in pain. I told him maybe it's normal. I asked him, is the pain increasing or decreasing? He told me that it was increasing. I told him to come and pass by. So he came by 9 days later on, and we can see here a very bad healing in this area, and we can see that the bone was not covered by the gum after even 3 weeks from surgery. This was taken, this picture, after 3 weeks from surgery. I was always hoping that the gums will close, and actually it was not closing. So at this time, I told the patient that we have a major complication and we have bone that was actually not covered by gum, and we will lose maybe some of it, maybe the totality of the bone. I really don't know, so we have to control. At this time, he told me that I lied to you. I really didn't stop smoking, and I was still smoking 3 to 4 packets per day. Nevertheless, the things actually got worsened, and you can see on the X-ray that we don't have bone on at least 3 distal implants. On number 45, 46, 47, we are losing the totality of the bone. So at this time, we decided to remove those implants. Okay, so when we removed those implants, some bone was mobile and was actually, it went out during my surgery. So 3 months after this implant removal, we can see that we have a complete or a major vertical bone loss after this case. I really wanted to show you this case because really in my practice, I only learned when I saw other fellow dentists showing their failures and how they were treated. I didn't learn from dentists that were showing only their success. I really wanted to show you this to tell you what could happen even with me. This technique, actually, I do it. I told you this is maybe more than 100 times I did this surgery before, and I didn't have any problem, and it happened. So now we are facing a different problem. Before we had a problem in the width of the bone, now we have a problem in the height of the bone. So now nothing will have to be done. Now we can see that we have a 12 millimeter vertical tissue height loss because of what happened. So now our only option is to do a vertical guided bone regeneration, trying to bring back all the bone that we lost and to place the implants back. To do a vertical posterior ridge defect, it's actually one of the most difficult surgeries to be done. Why? Because first of all, of the accessibility, it's really hard, especially when we want to fix the membrane from the lingual part. It is really tricky and difficult to do. This surgery must be done with 6 sterile hands. We cannot do it just with 2 assistants. I have to be working with 2 assistants, not only 1. And we have different steps that have to be respected in the majority. So if we have a problem in the incision, we will have a major problem. If we have a problem in the elevation of the flap, we will have a problem. So any step with problem will lead us to a failure, a complete failure of this surgery. One key success to this surgery is the passivation of the buccal and the lingual flap. This surgery before, actually it was described by Tinti and Pini Prato. It was the first time I saw it, and Simeon also, maybe more than 20 or 30 years ago. But sometimes it worked and sometimes it didn't work. Actually, the majority of the failures was an early exposure of the membrane. And the early exposure of the membrane was really caused by the not enough soft tissue covering the membrane. So the most important and the trickiest thing to do is the passivation of the lingual flap. The lingual flap must really be really pacified and go coronally more than 15 millimeters. The second tricky thing to do is the fixation of the membrane from the lingual part. It's really not easy to do. So the surgery started by doing the incisions properly, in crestal incision, vertical incision 2 teeth away buccally, and the vertical incision in the most distal part. Here you can see the lingual flap before doing the passivation. It goes up just 6 millimeter vertical displacement. After doing the passivation, we can see that it's coming out more than 17 millimeters. So this is the situation before doing our vertical regeneration. Of course, we collected bone from the ramus area from the same part, same side, so we didn't have to go to the other side. We had enough bone. One last implant was actually still in place since the last surgery. I kept it in place because I saw here a horizontal bony bridge. So I said, maybe we have a bone loss here that was caused by the infection that happened before. If I place some bone grafting around this area that maybe could not be actually contaminated from the buccal part because we still have bone here, maybe it will work. So this is what happened. I prepared the bone. I do those small corticotomies or small holes inside the bone just to bring more blood to this area and bring more osteoblasts to my grafting. The membrane used here is a cytoplast. I think this is the biggest size that they have. It's a non-resorbable polytetrafluoroethylene membrane with titanium reinforcement. This is a mix of 50% of autogenous bone and 50% of xenograft. Nowadays, it's better to place 60% of autogenous bone and 40% of xenograft. The membrane was fixed from the lingual part, the bone was placed, and the membrane was also fixed from the buccal sides. And we closed everything, as you can see, with a combination of U-shaped sutures or horizontal matrix sutures and separate sutures. Everything was good, and actually this time the patient really stopped smoking because he knew what happened, and he told me, now I really promise you that I will stop smoking. And as you can see, even though the surgery was much bigger than the first one, no complication occurred. This is 9 months after doing the vertical GBR. You can see here that the bone actually came back to its original place vertically. So we re-entered after 9 months. This is the membrane in place. So we removed the membrane, and we can see that the only implant that I kept, we even lost the horizontal bony bridge that we had. So we decided to remove it now when we will place the other implants. So the membrane was removed, and you can here see occlusally the width of the bone obtained and the height of the bone obtained. It was really remarkable. Some soft tissue was existent on the crest. It was okay. The last implant was removed, and I placed 4 implants in ideal position. I placed here another implant on the number 44. I placed it more lingually. I placed a smaller in diameter implant, and I did another bone grafting, and I closed everything. I took this x-ray because those implants, I wanted to place them 2 millimeters under the bone, because a bony, we can have a modification, or we can lose maybe 1.5 to 2 millimeters of the bone on the crest after maybe 1 to 2 years. This is why whenever we place implants, in those cases, those implants must be placed 2 millimeters under the bone. You can see here that the implants were placed, the drilling was actually more apical, so those teeth were placed more apically. So this was the situation before I started. This was the situation after the complete bone loss. This is the situation after doing our bone regeneration. So this is before, this is after. This is before doing the bone grafting, and this is after doing the bone grafting. And in conclusion, that I can tell you that the treatment of implant and bone graft failures really takes a long time. So we must count between 1 to 2 years to finish the treatment. They must be done on several stages. We don't mix all the surgeries together because we are increasing our risk of failure. Those treatments are traumatic for the patient because the patient was thinking that he actually finished his implant treatment, and now we have to restart everything all over again. And actually the functional and the aesthetic result, even if we have a complete success, is always inferior than if this treatment was done properly since the start. And I would like to thank you for your attention.
Thank you, doctor, for this nice presentation and these difficult cases. May I ask you, the membrane that you used, it was a PTFE membrane. Was it an ePTFE or an DPTFE?
It was an ePTFE. It was a cytoplast membrane. Cytoplast.
Okay. Here we got a question. Was there a special indication for cylindrical implants?
Actually, I use in my practice 2 kinds of implants. I use the cylindrical implants, and I use the tapered implants. The cylindrical implants, I use them for all the classical cases. I use the tapered implants for immediate loading and in some particular cases. In this particular case, at the end, you can see that I used cylindrical implants. Why? Because when using cylindrical implants, we have we can place those implants a little bit more apically or less apically without losing our primary stability. While when we use our tapered implants, they have a higher primary stability, but we cannot actually modify our position vertically, apico-cervically. While with our cylindrical implants, we can modify the position, especially after the surgery, where we have to modify.
And even these cylindrical implant made less pressure on the bone, I believe.
It makes less pressure on the bone, yes, of course.
Yeah. Dr. Najabut, please, can you refer to us the study who tells 60-40 is better mixture? Thanks.
Yes, actually, new studies by Urban, because actually I'm using his technique. Maybe I was attending his congress that he does in Budapest every 2 or 3 years. Last time we were there, maybe 3 to 4 months ago, he told us that he modified now his mixture to 40-60 and not 50-50 because he needed more autogenous bone in this area. I wanted to talk a little bit about the mixture, why xenograft and why autogenous bone. Autogenous bone, as you know, because the autogenous bone is osteoinductive, and we have living cells that will induct bone formation from